Very warm welcome to all of you. Today I'm going to be dealing with surgical endodontics. So this is a two-part seminar. Lecture we'll be reading about the rationale. We'll be dealing with the rationale for surgical endodontics. That means why, when, why you're going to be carrying it out. What are the indications? What are the contraindications? And you'll be given a brief introduction about the various steps you're going to be taking in today's lecture. Okay. So, what is periradicular surgery? It is supposed to be considered as an extension of your non-surgical treatment. By non-surgical treatment, I mean your regular endodontic therapy. So, why is it considered as an extension? Because the objectives of your treatment are going to be the same. At the end of the day, even with your surgery, you wish to prevent or eliminate the formation of your apical periodontitis. So it should not be considered as something which is separate from your non-surgical treatment. Should be considered as just an extension, even though the instruments and the techniques which are used are going to be. So what is the definition of endodontic surgery? These are the surgical procedures which are performed to remove the causative agents of your periradicular pathosis and which restore the periodontium to a state of biologic and functional health. So it's very simple definition. It is nothing but the procedures which are carried out to remove the causative agents. So your causative agents for your periradicular pathosis are bacteria, the byproducts of the bacteria, that is the toxins, and you want to restore the periodontium to a state of biologic and functional health. So you wish to clean the area, make it sterile, remove all the granulation tissue which will be formed because of the result of the byproducts and the toxins of the bacteria, and you wish to restore it to a biologic and functional health. Okay. Now, during the last 20 years, endodontics has seen a dramatic shift in the application of periradicular surgery. So, in the earlier cases, as soon as we see a periapical lesion, of moderate to large size, we used to immediately consider going in for periradicular surgery. However, nowadays, because of the advent of newer materials and newer techniques, we still wish to give our conventional endodontic therapy a chance before we actually jump into surgical intervention. Okay, so Grossman, a very famous dentist of his time, he had given a list of indications for endodontic surgery at that time. That was including the presence of large and intruding periapical lesions, just like how I said just now. Overfilled canal. So if there was GP, your Gatapacha was extending beyond the apex, then yes, surgery was indicated. Incomplete apical root formation. So this was given at a time when we probably apexification, apexogenesis was not very common, and the prognosis was not good because of the quality of the materials at that time, and destruction of the apical constriction by over instrumentation. Again, at that point of time, probably the intracanal medicaments and irrigants were not very good, which would not have facilitated proper healing, and they would not have had proper obturating materials also to deal with destruction of your apical constriction. So now, because we have proper techniques, we have very good materials, very good medicaments, we do not immediately consider endodontic surgery as the treatment. We still prefer to give your non-surgical endodontic treatment a chance, a fighting chance, before we actually consider surgery. So, with the advent of the microscope and microsurgical tools, your magnification has improved manifold. You have clearer access, and because of the smaller sized instruments, you are able to actually work more efficiently, because of which your prognosis and the outcome of the treatment has become much better. So, the chances for the case to actually be considered for surgery are quite lesser now when compared to the earlier days. However, if you are going to be considering, a surgical procedure, you have to, have a look as to whether the patient's systems are going to permit it. By systems, I mean the cardiovascular system, the respiratory system, so on and so forth. So, a medical history prior to surgery is very, very important. So now we are over here. We have the actual indications for your surgical intervention in the present day. So here we feel if your non-surgical treatment, non-surgical retreatment, so that is your retreatment of RCT with the help of H files, your endodontic solvent, that is your catapercha solvent, the use of intracanal medicaments has failed at least twice, then yes, we can consider our surgical intervention. When we feel that there is a persistent periradicular disease, that means we have performed your RCT, you have tried your re-RCT, and still you see that the periradicular lesion is not regressing, that is, it's not becoming smaller in size, or it is growing in size, then yes, we may have to intervene surgically. When there are true periradicular cysts, so yes, of course, cysts are not going to go away with just medication, they need to be enucleated. So yes, in those cases, we need to perform surgery. When there is significant overextension of filling material, so in this case, we feel that if the gutta percha has gone way beyond the apex, then yes, it may not be easy to retrieve it. So in those cases, we first try to retrieve. If we're lucky, then yes, with the help of H files and the solvent, we'll be able to remove the existing gutta percha. From the canal, yes, but from the periapex, of course, we cannot place the solvent because the solvent will cause severe pain and irritation to the tissues. So we can only try it with the help of H files. If it comes out, well and good. If it doesn't, then yes, surgical extension, surgical management will be required. However, please remember, if your root canal sealer has gone beyond the apex, you do not require surgical intervention because the sealer will regress on its own, okay, over a period of time. Now, the other indications are when your retreatment is not possible. So that means when you are not able to perform your endodontic treatment after certain tough cases, like when you have placed a long post in the canal. So in these cases, a removal of post is easier than it sounds, because it's not something which can be accomplished by everyone, and it's not something which can be accomplished every time. A certain amount of luck also will be required, okay, because the posts are going to be cemented into the canal. You can try using your ultrasonics to disengage the post. That means you engage the ultrasonic tip at the junction of the post and the tooth surface, the hard tissue surface, and then you start using the ultrasonics. So with the vibrations, the post can become loose. Again, I'm specifying it can become loose, because of which you can remove the post. However, it does not happen every time. So in such cases, when you see that there is a periapical lesion, you may want to think along the lines of surgery. Irretrievable separated instruments. So if a file has been separated in the canal and it is compromising on your cleaning and shaping, or you feel that the file has gone beyond the apex, yes, we may have to perform surgery if we are not able to retrieve it. Uh, Ledges have been created during your cleaning and shaping which are non-negotiable. In such cases, yes, the cleaning and shaping is compromised, and the formation of a periapical lesion is possible. So yes, in those cases, later on when you see that a periapical lesion has formed, yes, you will have to perform surgery. There's no other way other than extraction. Canal blockages or transportation. So if the canal is calcified, so it's not your fault, the canal is actually calcified and you are not able to proceed with even the working length. Or transportation, that means you have created another path other than the actual path of your traditional root canal. In such cases, yes, you may require surgical intervention. Hard cement filling material. So you have used something like MTA or biodentine to perform your apexification or apexogenesis. The patient comes back after maybe 10-15 years and you see that there is a huge lesion. Okay, it is not going to be possible for you to actually go through your MTA and biodentine because they are very very hard materials. It's not easy to remove it. So in such cases, you will have to perform your surgical endodontics. Vertical root fracture, it is an indication for surgery. However, I feel that as soon as you see a vertical root fracture, it actually depends on the extent of the fracture. So, if the vertical root fracture has extended till the tip of the root, I would say the prognosis is really really poor. It's just better to go ahead with extraction and replacement with the prosthesis. So vertical root fracture, I wouldn't consider it as much as an indication for your surgery. Then of course, when a biopsy is necessary, so in cases when you wish to send a sample of the granulation tissue for biopsy to check what you're actually dealing with, what kind of a lesion it is, then yes, you can perform your periradicular surgery. So what are the relative contraindications? So the first and foremost is the patient's medical status. So you have to check, have a detailed conversation with the physician of the patient. If the medical status does not permit, so if the patient is medically compromised, you know that the healing is going to be delayed. You know that the surgery is going to take a considerable amount of time. Sorry, the surgery is going to take a considerable amount of time. There's going to be a significant amount of bleeding. You're going to be prescribing some sort of medications. So all of this should not intervene with the health status of the patient, because of which you need to actually have a detailed conversation with the physician, and then you can decide whether the patient should be prepped for surgery or not. Anatomical considerations. So if you feel that during your surgery you're going to hit one of the important landmarks like the maxillary sinus or the mandibular nerve, then you have to actually give it some serious thought, because complications can be quite troublesome if you actually hit one of these anatomical landmarks. The practitioner's skill and experience. So we cannot, of course, expect to be good at surgeries right from the beginning. So this is something which comes with practice and which comes over experience, over a period of time. So if it is a very complicated surgery, I would suggest that you don't try to, be a hero, and you actually refer it to someone who has considerable experience in this field. So, like I said, if the patient is medically compromised, you actually have to have a consult with the physician of the patient, and you have to actually explain. So, you can actually give it in writing, that's more than enough. You can actually describe the procedure with what you're going to carry out, the anesthetic agents which are going to be used, the medications which are going to prescribe, the approximate time which is required for the procedure, and the length of the recovery phase. That means how long you expect the patient to actually take to recover from this surgery. So in this way, the physician can actually assess the risks which may be involved for the patient, and can assist the dentist in determining the appropriate treatment modifications. By treatment modifications, if you actually have to absolutely carry out the surgery, the treatment modifications can be preoperative. That means you can decide on the drugs which you have to prescribe. That may involve the anesthesia also, the normal antibiotics also. The intraoperative is the sedation which you may require, and the postoperative, that is again your drugs and your sedatives and analgesics. So you may have to modify the drugs which you are going to be initially thinking of, and sitting together with a physician, you can come up with an alternate drug plan. Yeah. Okay, so like I said before, the major anatomical considerations which you have to take into uh, mind before you perform your endodontic surgery. The first and the foremost is the nasal floor, then you have the maxillary sinus, the mandibular canal, and the mental. If you feel that any of these landmarks are going to be hit when you are performing your surgery, you want to reconsider, because it can lead to potential side effects. Okay, so this is the classification of your endodontic surgery. We will be discussing about each of them in the later slides. So here I'll just tell you about the different terms. So you have incision and drainage. This I'm sure you can see in the Department of Oral Surgery also. So if you have a large intraoral swelling, or an extraoral swelling, we generally give a stab incision intraorally, and we that which facilitates the drainage, so the removal of the exudate and pus with the help of high volume suction. Cortical trephination is a continuation of incision and drainage, I would say, because this cortical trephination is going to be done in cases where you cannot actually see any clinical features. That means you cannot see an obvious swelling, you cannot see any obvious discharge. However, on radiographic intervention, you can actually see that your endodontic therapy has failed and there is a periapical lesion, and because of which the patient is in considerable pain. So in this case, you're going to actually have to drill through the bone, reach the periapical area, and then relieve the exudate and the pus. That means you can facilitate your drainage. So this is going to give some sort of, not some sort of, quite a lot of relief to the patient. Okay. Decompression, again, it is to reduce the size of lesions. So you can do decompression. Curettage. Now coming to your periradicular surgeries, that this curettage is something like cleaning up the area around the root from and to remove all the granulation tissue. You are degranulating the area. Root end resection is carried out. You will be taught about it in the later slides. That you actually have to cut off at least 3 mm of your root surface, the root end. Okay. Then after that, you have to prepare the root end to receive a root end filling. So this will be described in the later on slides. Corrective surgeries, this can be done to repair your perforations. It can be done for periodontal management. That means you would like to resect your root. You want to do something like a hemisection or a bicuspidization, and even intentional replantation. So in the cases where you see that the tooth is having a large lesion, and you want to do so you can actually atraumatically extract the tooth, perform the endodontic therapy, do a little bit of degranulation in the extraction socket site, and then replant the tooth. Yeah. So that can considerably improve the prognosis. However, the chances of failure are also there in the cases of intentional replantation, because of which it is not actually practiced very widely. Now, most periradicular surgical procedures will share a number of these concepts. So, please keep in mind that these are some of the concepts which are going to be dealt with. However, not all cases will require all of these concepts. Okay. The first is the need for profound local anesthesia and hemostasis. This, irrespective of what procedure you are doing, you have to give profound local anesthesia and hemostasis. So, in such cases, please understand, you cannot give your infiltration, your nerve blocks are mandatory. Okay. And you have to use your hemostatic agent, that is your adrenaline. So you cannot give the non-adrenaline injections. You have to have your vasoconstrictor because you have to arrest the bleeding. Management of soft and hard tissues, this has to be done. That means you have to give your soft tissue incisions, you have to drill through the hard tissues to reach the surgical site. You have to gain surgical access, both visual and operative. So you should be able to see what you're doing, and your operative instrument should actually be able to enter into the area. So you have to have sufficient surgical access. You have to have access to the root structure. You have to do periradicular curettage to remove the granulation tissue on and around the root surface. You have to then you will be dealing with root end resection. Like I said, you will have to cut 3 mm, at least 3 mm or more than 3 mm of the root end. You have to prepare the root end to receive a restorative material. So nowadays we prefer to use MTA and biodentine. In the earlier days, even amalgam was used. Yeah, amalgam was used, GIC was used, but then of course, because of the side effects of amalgam, that means the discoloration and the fear of toxicity, amalgam was discarded. GIC, because we are not able to achieve a moisture free area, so GIC has also been discarded. So now we have come to MTA and biodentine. So these are much better root and filling materials. Soft tissue repositioning and suturing, of course, has to be done, and of course, post-surgical care. So we have to counsel the patient, and we have to prescribe the analgesics and antibiotics so that the patient can recover. So coming to incision and drainage, here I've attached a link which will take you to an incision and drainage case. So you will actually see a surgical opening is going to be created in the soft tissue just for the purpose of releasing your exudate and your pus. Yeah, so it is a very simple procedure. You can see the video, and if you have any doubts, you can contact me back. There is again a video which is attached, so you can actually have a view. it is something which I just described earlier. So in these cases, the patient will have severe endodontic pain. Okay, there is no clinical features of swelling, either intraoral or extraoral, oral, and you cannot establish any drainage through the root canal. So even if you remove, your permanent filling, you may find that there is a post there, or you may find that there is a presence of a ledge, because of which you are not able to gain access to the apex, because of which you are not able to accomplish your drainage. So in such cases, you may have to go ahead with cortical trephination. Okay, so the patient will benefit with this, because the severe pain subside. So the video, as I said, is attached over here. You can have a look, and if you have any doubts, please feel free to contact me. Now, apexum is a recent concept to actually remove your periapical lesion. So it helps to deal with a periapical lesion. So in these cases, you don't need to consider doing your conventional surgical procedure. So it is just a kind of an orthodontic wire which is going to be introduced into the surgical site. That means into the area where the periapical lesion is. So let us assume that there is a large periapical lesion. You are going to introduce a surgical wire. So it will be like the thickness of your orthodontic wires, and this wire is going to be rotated at a high speed. Because of the rotation of this high speed, it is actually going to clean up that area. It is going to remove or scrape off all the granulation tissue from that area, and then that area can be cleaned, and you can place a medicament like your calcium hydroxide, or you can actually place your MTA or biodentine, and then it can lead to proper healing. So you don't actually need to sacrifice, surgically. That means you don't have to create a large operating site. You can just introduce this wire, and you can actually just clean and irrigate that area and help and facilitate better healing. So you can see the video, and it's quite easy to understand. Now coming to your flaps. So in the conventional surgical methods, unlike the apexum, you're going to have to give your periradicular flaps. So you need to know what is a flap, the different kinds of the flap surgeries which can be considered. So a flap is a section of tissue such as your gingival mucosa, which will be partially detached from the underlying tissue but retains the blood supply through an intact base. So this is very important. So you're not actually removing the entire chunk of tissue. It is going to be detached from one part, but it is attached to the major blood supply source, so that portion is still vascular. So that when you reposition it back, the blood circulation will actually help in the healing of the flap site. Okay, so you depending upon the position, you have different types of flaps. This will be covered, this I'm sure would have been covered in your department of periodontics as well. So you have your apically positioned flap, your lateral or vertical sliding flap. Then you have, based on the shape, you can have your semilunar flap, the rectangular flap, the trapezoidal flap. In the department of endodontics, we generally go in for a trapezoidal kind of a flap. The reason will be disclosed in the later slides. Then based on the location of the incision, it can be either intrasulcular, it can be submarginal, or it can be vertical. Okay, so for endodontics, we actually have a combination of your vertical and your intrasulcular, or vertical and your horizontal incisions. Okay, so it is going to be a combination to create a trapezoidal flap. Then you have your full mucoperiosteal flap, and then you have your limited mucoperiosteal flap. So the full mucoperiosteal flap involves the intrasulcular incision and includes the epithelium, attached gingiva, alveolar mucosa, and periosteum. The two examples are the triangular and the rectangular flap. Whereas the limited mucoperiosteal flap, it involves a submarginal horizontal incision. So the full mucoperiosteal involves the intrasulcular. So that means you are actually involving the sulcular region. Whereas in the limited mucoperiosteal flap, you are actually going 1 to 2 mm above your sulcular area. So it is a submarginal incision. So you are not actually involving the sulcus area. Okay, but it includes the epithelium, attached gingiva, alveolar mucosa, and periosteum. So the examples are your submarginal and your semilunar flap. So your full mucoperiosteal flaps, the examples are your triangular flap, your rectangular flap, the trapezoidal flap, the horizontal flap, and the papilla base flap. Okay. So in this full periosteal, so the base, the one end is always involving your the sulcular region, and of course you have the other end which is high up in the alveolar the marginal or the attached gingiva. Yeah, and in the limited mucoperiosteal flaps, you have your submarginal or the semilunar, which is not advocated anymore because you can't exactly gain very good access to the surgical site. However, you do have the loop Oschenbein flap. This is the submarginal scalloped rectangular. So this is the most commonly practiced flap in endodontics right now, other than the trapezoidal. Okay, the broad-based rectangular flap. So here you have the diagrams, the diagrammatic representation of your full mucoperiosteal flaps. So as you can see, the sulcus is involved in all of them. So you have the triangular, you have the trapezoidal, you have the rectangular and the horizontal. And this is the papilla preservation or the papilla base flap. So you are actually preserving the papilla. As you can see, the papilla is actually left behind over here, and you have given a flap. Then you have your loop Oschenbein flap over here. As you can see, it is submarginal, so it's not involving the sulcus. You are actually going 1 to 2 above uh, your cervical third of the teeth. Yeah, and then you are giving a sort of a trapezoidal or a broad rectangular kind of a flap. Semilunar flap, like I said before, it's not very advocated and not very popular nowadays because of the lack of access. Now coming to the principles and guidelines for the flap design, each of these is going to be discussed in detail in the future slides. So the first is to avoid the horizontal and severely angled vertical incisions. This is because your blood supply is going to be disrupted. Okay, I think we'll just go on to the future slides, the later slides, so that you can actually have a look. So coming to the principles and guidelines for your first is you should avoid your horizontal and severely angled vertical incisions. So as you can see, the blood supply of your gingiva is actually in a vertical manner, as you can see in the picture on the slide. So if you give a horizontal or a severely angled vertical incision, you are actually going to be compromising the blood supply of the gingiva. So your healing is going to be delayed. That is why we we wish to give the vertical incisions and the intrasulcular incisions. It helps in better or faster because the blood supply is not compromised. Yeah. Also, another disadvantage of your horizontal and severely angled incisions is that they shrink excessively during surgery because of the contraction of the cut collagen fibers which run perpendicular to this line of incision. So if you give a horizontal incision, the collagen fibers are actually running perpendicular to it. So they are actually aligned, parallel to the long axis of the teeth, because of which they are going to shrink excessively, and it's going to become difficult to reapproximate the flap to the original position without actually causing any tear or excessive tension to the soft tissue, because of which you are going to have scar formation. So these are the two reasons because of which you are supposed to avoid your horizontal and severely angled incisions. Now, the second is to avoid your radicular eminences, because if you actually give your incision on the radicular eminence, so you have to understand the soft tissue is very, very thin in these areas because the root is actually protruding. Yeah, the root surface is protruding. You will do fenestration, because of which your cortical bone is going to be exposed. Yeah, and in these areas, because of this defect, the blood supply is going to be very poor, because of which the healing is going to take a very long time. So there's going to be very poor healing. So this is why you avoid giving the incisions over the radicular eminences. Okay, you just give it lateral to it, so either mesial to it or okay. You have to avoid major muscle attachments because if you involve the incision in the muscle, it is going to be very difficult for you to reapproximate the tissue back when you want to give the sutures because the muscle has been incised and it is going to delay your healing. Your tissue retractor, when you are going to be using it to retract the soft tissues, it has to rest on solid bone, otherwise it is going to damage your soft tissues if it is resting only on your soft tissue. So it is going to damage your soft tissue. It might lead to necrosis of the soft tissue, because of which your blood supply is going to be hampered. Then of course you have to have your good visual and operative access, and you have to give a full thickness flap. If you give a partial thickness flap, you are not going to have sufficient amount of healing. So the full thickness flap means you are incising all the way to the bone till you can actually have contact with the bone. That helps for healing. Okay. Then you have to decide whether you want to include or exclude the interdental papilla. Both are okay. However, we prefer to include the interdental papilla for cosmetic reasons, because then the entire thing can be reflected back and then sutured. It will have a more natural appearance. In the cases where the interdental papilla have been excluded, you have to suture it back, and the suture point might include the interdental papilla also, because of which that they might cause a tear in the interdental papilla also. So you might have a slight scar in that region. So it will not look very good aesthetically. Incision should be placed and flaps repositioned over solid bone. This I have told before also. So the incision should never be placed in the areas of the bone loss. So you have to understand that your surgical site should extend beyond your pathological site, and it should include some amount of healthy tooth structure also, healthy bone structure also, because if you incise over the area of periodontal bone loss or periradicular lesion, you will not have good bone support and you will not have good blood supply. This will result in necrosis and poor healing of the surgical site. Okay, so two scientists, Hooley and Whitaker, they suggested a minimum of 5 mm of healthy bone should exist between the edge of a bony defect and the incision line. So that is the amount of the extent of your surgical site which you should consider. So let us assume that you have periapical lesion on the lateral incisor. The ideal extent of your flap should extend at least to the distal side of the canine on one end, and at least to the lateral side of the lateral incisor, the mesial side of the lateral incisor on the other end, or the distal side of the lateral incisor of the other end. This will become more clear when you have a clinical picture, so it will be easier to explain. Okay. Major muscle attachments, I said it is difficult. You have to avoid it. You have to bypass it, because repositioning the flap and healing will be much more difficult, and scar formation will happen. This is why you are supposed to bypass the muscle attachments, and you should include the muscle inside the flap itself. Do not try to. Okay. Tissue retractor should rest on solid bone. This again I told you. If it is not resting on bone, and if it is resting only on the mucosal tissue, it will affect the blood supply and it will result in delayed. Okay. The extent of the horizontal incision should be adequate to provide visual and operative access. This is what I was talking about. So let us assume your maxillary right lateral incisor is the tooth of interest. Okay, so you have a periapical lesion for the maxillary right lateral incisor. So your extent of your flap should deal with at least the distal side. So your vertical incision should be at least on the distal side of the maxillary right canine, and the other vertical incision should be at least on the mesial side of the left lateral incisor or the distal side of the left lateral incisor. It's a little confusing when it is said in words. So if when we meet in the clinics, giving a pictorial representation will be much easier. Okay. So this will give adequate amount of access for you to actually work without actually causing tension and stretching of the soft tissue. So rather than working in a small site, it is in a cramped up site. It is better to create a larger site where you can work comfortably. The junction of the circular and vertical incision should either include or exclude the involved interdental papilla. This you had seen in the diagram behind in the previous slide. So what we prefer is that we include the interdental papilla. We don't exclude it for cosmetic reasons. Okay, and the interdental papilla should never be split by the vertical incision. So the vertical incision should either be distal to it or mesial to the interdental papilla. It should never be in the middle. It should never split it because the healing will be poor. And we always want a full thickness flap. We do not want because the partial thickness flap will have more trauma to the soft tissues and delayed healing. So the full thickness flap will have the entire blood supply, because of which